respected Chief Instructor, Dr. Lahan,
Yes.
and others, honorable audience and residents. Good afternoon and Assalamu alaikum. First of all, I am very much pleased to thank the organizer of AIOS to invite me to talk here. My topics on tail flap in eyelid reconstruction is innovative evaluation. All over the world nowadays, many new techniques for eyelid reconstruction they are doing, and these are changes day by day. But our goal, but every eyelid surgeon have the goal to maintain normal anatomy of the eyelid as well as protection of the globe, and last of all, what's very important is acceptable cosmesis. To maintain normal anatomy of the eyelid, we have to respect skin matching along with smooth congenital surface, and structural support of the eyelid is very much important. Skin matching, one of the most important matters, but which skin is best match with the eyelid skin? But eyelid skin is not sufficient, then we have to go post and pre-ocular skin than others. For a smooth conjunctival surface, a small defect, we can use the conjunctiva of the same eye, and large defect, we can use the conjunctiva of the other eye. And buccal or level mucous membrane, and amniotic membrane gap also. Just an overview, simple overview, quick overview on lid reconstruction basic. All of us know that if defect is less than 25%, direct closure, 50% canthotomy or cantholysis is semicircular flap. My topics is on that. 50% lesion, canthotomy, cantholysis of semicircular flap or tendril flap. Just there's a modification of tendril flap. My today's topic, just a quick overview, direct closure. Tarsal plate margin should be parallel to each other. Cartilage beard procedure is popular for all oculoplastic surgeons. Upper lid reconstruction by the lower eyelid. This is the procedure, the first stage, and this is the second stage. And another procedure, huge flap, lower lid reconstruction of the upper lid, first and second stage. My talks on semicircular flap and tail flap comparative evaluation. In semicircular flap, we have to doing canthotomy, cantholysis, and making a semicircular flap, and the preoperative and postoperative view. Tendril flap is lateral inverted or reverse flap, cover up to 2/3 of the eyelid defect maximum, but usually doing 50% defect. It is a semicircular flap, beginning at the lateral canthus and can go externally outward up to 2/3, 3 centimeter. Lateral canthal tendon is severed cases. Complications, lateral canthal webbing, ectopy on lid notching, and seminiform tissue fullness of lateral lid may be. But tail flap, it is a flap like a tail. Call it triangular flap maybe. Length should be double the size of the defect. In tangent flap, length of the flap is double the size of the defect is same. Incision start from the lateral canthus, and tail flap also from the lateral canthus. It is obviously upward, obliquely upward, and downward laterally. Middle is order tail flap. It is a tail flap like a tail, It is oblique flap, upward and downward. It depends upon the whose lid I have to reconstruct. This is the photograph of tensile flap first. Height is on average is 20 millimeter. Length is 30 millimeter if defect is 50 millimeter. But it's tail flap versus tendon flap. Length is same down the defect, but height is minimum. 10 millimeter just equal to depth of the fornix. But we can increase the depth also, height also, according to need of the patient. We can use it. Lower lid, it goes obliquely upward. Upper lid, it goes obliquely downward. Here, lateral canthal tendon is severed in both the cases. The video of tensile flap side by side with tail flap. Video is not good quality. It is done by me. First video is tensile flap. Second video is the tail flap. Defect in the upper lid. That case is defect in the upper lid. But in tensile flap, more tissue is involved. In tail flap, tissue involvement is less. And in tail flap, it is simple to operate. Formation of medial canthus, lateral canthus in the tail flap. More tissue is involved in tensile flap. We use a semicircular flap. Tail flap is very simple, simpler than tensile flap. Before surgery, after surgery, tail flap. A pictorial view, pre-operative, per-operative, post-operative cases of tail flap. Another video of tail flap of lower lid. Growth in lower lid. Previously, the biopsy have been done is BCC. Inform the lower lid, margin alone. All the operation done in position control. Specimen are taken by sharp cutting without damaging the margin because they're sending for position control. Initially not using the cautery because we're waiting for biopsy report. Then marking for tail flap. It depends upon how much its length is, it depends upon the defect. Generally, double the defect. Length is double the defect, just like tangent flap. It can apply to all the cases, not only in the malignancy, but we can use it in coloma also, congenital coloma also. Perforative, then looking to be very tight, but after surgery, post-operative patient, the pictorial view of the same patient, pre-operative, post-operative, measurement, post-operative, and marking, and then last of all, post-operative patient. Eyelid coloma, a patient having T-Charcot syndrome, lip is repaired, and then the same thing, tail flap, before surgery, after surgery, another patient. The upper lid coloma, bilateral upper lid coloma, same time in both eye, tail flap, another patient. Tail flap is a new technique for both upper and lower lid reconstruction. It is easier to perform. And learning curve is very less time consuming. I feel less time consuming. And complication more or less complication. Cosmetically, more acceptable because less scar is there. In conclusion, it is a very small case series I have tried by this technique. But merits and demerits comparable to the tangent flap could not be commented right now. Study of large series of cases required for the future comment. Thank you all of you. Assalamu alaikum.